Hello, welcome. We are the National Indian Council on Aging, and this is our Tribal LTSS Assisted Living, the Nursing Home Alternative webinar. My name's Becky Al Morgan, and I will work as a project coordinator here at NICOA. Thank you for joining us today. Our presenter has a fascinating talk planned, and we want to hear from you as well. But first, our executive director, Larry Curley, would like to offer a prayer to start us off in a good way. Larry?
Thank you, Becky. I will do this prayer in my native language, which is Navajo. Alane no stan shema yadel shija dishingo koni janai ani ba hetani zeno that the shnikore ado the nehade shi tanihini sagi yego ado le yan sita keski yat na de kato le himasani ki chedan leni ba date hot are yakode hinane shide leni ba hetani zen ado konti shingo at in the corner kayas ado en das en de she yat na de ni kato le a hodn tro na de ni kato le a hodn tro sena de kirso le Joniko Hata William Nasta any Carly, what I Codotis Jingos Aya, what are Sisaco Conda Sols and a nanish letter let Vision Hustling, Vision Hustling, Vision Hustling, Vision Hustling, end the prayer.
Thank you, Larry. Today, I would like to ask if you could please put your name and where you're calling in from. So for example, I'm Becky from Albuquerque. It's nice to see all the different places and people that are living and working in Indian country that are joining us today. Our organization, the National Indian Council on Aging, or NICOA, is a nonprofit that was established over 40 years ago, and it has been and remains dedicated to improving health, social services, and economic well-being for American Indian and Alaska Native elders. Thank you to our very knowledgeable presenter, David Wilgen. We are so excited to hear from him and have him share his experiences and to learn more about assisted living. And I want to also thank the great team at NICOA who helped to create this event, Larry Curley, Kayla Sawyer, and Desiree Lapahi. Let's cover a few housekeeping details now. Turn the slide. We'll be taking a 10-minute break near the halfway point of the webinar. And we are recording this session and we'll post the recording on our NICOA website within several days. You can find it at the top of the homepage at nicoa.org by clicking newsroom and then videos. We encourage your questions always. You can type them into the chat box, and then you can also click the raise hand feature and we can unmute you. And we found that that's really a good way to, have a good direct conversation. And so the way to do that, I will attempt to demonstrate, is if you go to the bottom of your screen, and then you click over, and I'm not sure because this looks a little different, but if you go down to the bottom and explore, I believe, well, I'm sorry, I will try to find out and let you know, but raising hand is the best way if you can, if you don't like to type. Then if you run into any technical difficulties, please share them in the chat and we'll try to troubleshoot. Sometimes the best approach is to leave the meeting and then join us again. Sometimes that fresh start can be helpful. We'll be seeking your feedback, so join in by sharing your questions and comments, and we'll make this as fun and interactive as possible. As part of the work of NICOA, and with the support from the Community Administration for Community Living, we created the Tribal Long-Term Services and Supports National Resource Center. The name that we gave the project is LTSS Compass, because our goal from the beginning was to make finding your way through confusing processes and regulations easier for elders, tribal leaders, and Native communities in general. So please take a look at our website at nicoa.ltsscompass.org, and I'll put the link in the chat later on. We're presenting 3 webinars on home healthcare, assisted living, and program management. Desiree Lapahi, our data analyst, will explain the process for choosing those 3 topics. Desiree?
Hi, everyone. Good morning, and we're happy to have you here today. As Becky said, I am Desiree Lapahi. I'm the data analyst here at the National Indian Council on Aging. So to talk a little bit about the survey, part of the cooperative agreement with the Administration on Community Living was to provide technical assistance to tribes in the development of the tribal LTSS program. So in order to figure out what tribes needed help with, we did a tribal leadership LTSS survey, and we requested the tribes to fill out and to help NICOA figure out relevant topics that tribes needed help with. From the tribal leadership survey, we had 85 respondents from across the US, and we identified 3 major categories. We identified infrastructure, supportive service, and management. And from those categories, we narrowed it down a little bit more. So from the infrastructure category, the #1 requested technical assistance was assisted living, which leads us to this webinar today.
All right, thank you, Desiree. And now I want to share the biographies of the subject matter experts that you'll be hearing from today. David Wilgen has a master's degree in public administration and is a licensed nursing home administrator. Mr. Wilgen is an experienced CEO of life plan / continuing care communities, including assisted living and post-acute rehab skilled nursing facilities, with over 40 years as a healthcare executive with not-for-profit faith-driven corporations. He is a multi-state licensed nursing home administrator. Over the past 8 years, he's engaged in consulting and interim CEO, executive director, administrator positions. He finds it rewarding to use his many years of experience to help senior service providers. Our other expert today is Larry Curley. Larry Curley serves as the executive director of the National Indian Council on Aging and is a member of the Navajo Nation, with over 40 years of experience working in the aging and healthcare fields, collaborating with Congress, other branches of the federal government, and national organizations on aging. Larry developed support for programs affecting elder American Indians and Alaska Natives. Mr. Curley received a master's degree in public administration and a certificate in gerontology at the University of Arizona. In Pima County, Arizona, Larry's work as a gerontological planner was instrumental in establishing a county public fiduciary program. In Washington, D.C., he worked as a lobbyist to successfully advocate for the passage of Title VI of the Older Americans Act, an amendment he authored. Mr. Curley directed the Navajo Nation's Head Start program, one of the largest Head Start programs in the U.S. Additionally, he continued his legacy of elder advocacy as a nursing home administrator of a tribal long-term care facility, as a hospital administrator in Northern Nevada, and as a college instructor at the University of Nevada, Reno, and Eastern Washington University. Mr. Curley was named Assistant Dean of the Four Corners Region for Burrell College of Osteopathic Medicine. He served as public representative on the American College of Physicians Clinical Guidelines Committee and as a director of program development for the Rehoboth McKinley Christian Healthcare Services in Northwest New Mexico. Thank you all for being here. And now I'll turn it over to Mr. Wilgen. And Mr. Wilgen, just let me know when you need me to advance the slides.
Okay, thank you, Rebecca. Thanks so much. And thank you, Larry. Well, I'm excited today to be here with you. And I hope when it's all said and done, we've all learned a little bit more about assisted living and how great an opportunity it really can be for many older persons. First thing I'd like to do is kind of talk about the difference between assisted living facilities and skilled nursing homes. Oh, I think we're going to first do this. I'm sorry. Larry and I are going to reminisce a bit about University of Arizona. We both went to the same graduate school back in the olden days, as parents used to say. And when back then there were only 2 programs, master's graduate programs in the whole country that offered a master's degree specializing in retirement housing and long-term care administration and gerontology. And One was in Texas, and the other was the University of Arizona, where we both attended and became classmates and good friends ever since. Larry, you want to add something to that?
Oh, yeah, Dave and I and a few other classmates, we worked well together. We studied well together. And whenever we had projects to do, Dave was always the lead person that was putting everything together and getting the classmates together.
Mhm.
And I think that we were very fortunate in a lot of ways in having an individual that was heading the program by the name of Dr. Ted Koff, who is known today as the father of adult daycare and hospice programs in the country. And for me, and I hope, and I think for Dave as well, he was our mentor. He taught us a lot, and we learned a lot, and brought the compassion and the passion for working with older people and instilled it in us. And I think he was a great individual. And unfortunately, he is gone now, but his legacy continues. Dave?
Yeah, Larry, that's true. Absolutely true. Dr. Ted Koff was very instrumental in both our lives and the lives of the other students there as well. And I worked with him for many years thereafter. And it's interesting and sad in that he was such an expert with respect to especially the care of the frail elderly. He never really lived to be old. He left us about 20 years ago. And anyway, it was a wonderful experience, wonderful gentleman, and we had a great time. And also back then, because there's only 2 programs in the nation, by the gifts we were given to go there, it really helped our resume and helped us open a lot of doors. And I hope one of my hopes today is that the authorities will again fund programs like this so that young people can be encouraged to go into long-term care administration, assisted living administration, and gerontology and so forth. Well, let's go to the next one. I think we're going to talk about the difference between assisted living and skilled nursing. Or Larry, were you going to talk about tribal demographics there? I can't wait.
I think that what we're now looking at is the webinar objective. And what we want to do is provide information and have a discussion about where assisted living ideas came from and how they developed as an alternative to long-term care, skilled nursing facilities, etc. So next slide, please. And here, what I wanted to share with all of you is that there are over 574 federally recognized tribes and Alaska Native villages in the United States today. And a few years back, maybe 15, 20 years ago, there's about 300 and something. So there has been a lot of tribal activity where they have been going to the federal government to be recognized by the federal government, having that unique status. There are approximately 326 Indian land areas in the country referred to as reservations, as colonies, as pueblos. And so there are 326 pieces of land out there that are held in trust on behalf of Indian tribes across the country. They say that in the recent 2020 census that there are about 9.7 million American Indians, Alaska Natives in the United States today. This is up from about 5-point-something million from the 2010 census. So it's increasing by tremendous amounts of percentages, much faster than the larger population. I think one of the reasons and one of the concerns that we have here with the National Indian Council on Aging is the beginning to take a look down the line in terms of time, 10, 15, 20 years down the line. What we're finding is that in terms of Alzheimer's and dementia, that there was a study that was done by the University of Washington a few years back, a couple of years ago, of tribes in California. And what they found was that in the larger population, 1 in 5 elders are going to be diagnosed with Alzheimer's or related dementia within the next few years. But in the American Indian community, they found that 1 in 3 will be diagnosed, which is a much higher rate than the larger population. And I think going along with this, while we're talking about the growth and the numbers of elders that are increasing, is that there has been a revitalization of tribes interested in their tribal language and their tribal customs. And I think most of this has been exacerbated by the fact that the pandemic made tribes realize our elders are very important. They're vital to the continuation of the tribe as a tribe with a unique history, culture, traditions, language. And so in this whole approach to assisted living, we need to remember that whatever we decide to do, that the facility itself is immersed and inculcated with tribal customs, tribal language, and tribal traditions, so that it's not something that you want to create as a model after something that happened in New York or Michigan. Yeah, so it's got to be something that fits the tribe. And so with that, Dave, back to you.
That's an excellent point. Absolutely. Well, some of the differences here between assisted livings and skilled nursing facilities, assisted livings are known to be safe and supportive housing. People are looking for that, and health with activities of daily living, and a non-medical kind of a model. Service groups in levels, that has to do with the different calculation for fees, as well as the way services are rendered in most assisted living facilities. I'll come back to that. In skilled nursing facilities, there's a provision, of course, of medical services supervised by a physician, licensed nurses, and therapists are at hand in caring for people, and there's extensive care for the non-independent. And that kind of sums it up generally, the difference between the two. And let's have the next slide. I think I wanted to talk to you a little bit, if I may, about the history, the evolution of assisted living facilities in this nation and in some degree around the world. But back in the 1980s, 85 to 85 or so, there was a lot of distaste for nursing homes, many of the for-profits, especially by the general public. And there was a paradigm shift. Some leaders on both coasts, the East and the West Coast, came up with a better idea, they thought, for elders living in an institutional setting. And they strived to have it be a much more residential environment where there would be not just a focus on their needs, meeting their needs, but also on dignity, on independence, on having privacy, those kinds of things. And so a model housing environment was created and began to be operating back in between 1980 and 1985, especially out in Oregon. And then in 86 to 93 or so, give or take, there was this began to be known by the public much more, and providers emerged. Consumers began to know more about it, families and so forth, and state governments got involved with some funding possibilities. And it's also when the Eden alternative approach came into being, and a man by the name of Dr. William Thomas developed the Eden approach, which was really to be much more humanistic in these environments, bring in outside life, if you will, plants and animals, and let the residents do more self-determination of their daily activities. And it started to appear in the literature. So more and more popularity of assisted living environments became apparent. And then during the 96 to 2000 was a huge period of expansion. It really caught on. A lot of Wall Street investment was occurring. A multi-facility corporation started to emerge. But there also were a lot of quality concerns that emerged, because many of these facilities, especially the for-profits where they're looking to just make money, they would keep people too long when they should have been referred on to a higher level of care, onto a nursing home, if you will, or the hospital or something. And And so there were a lot of care infractions going on. And so the regulations became much more stringent by various state governments and the federal government during that period of time. Tremendous growth and expansion. And then between 2000 and the present, continue to see tremendous growth in ALF, assisted living facilities, and increased competition with nursing homes. Again, more stringent regulations, but also the criteria to get in was relaxed with certain provisos. For example, you could have hospice come in and care for someone dying rather than send them off to a nursing home. And there was also the emergence of memory care dementia programs. And today there aren't that many. About 15% of assisted living facilities have some kind of a dementia or memory care, memory support program. And as Larry was talking with respect to the Indian nation, there's a tremendous need that's present and will probably continue. So that's a huge area of opportunity, I would think. I think the next slide talks about assisted living facilities today. There are about 28,900 facilities nationwide. That's just under 1 million beds that equates to an average size about 33. Some are as large as a couple hundred and some as small as 8. But 33 is about an average. We'll talk about it a little later, but you need to have or should have enough economy of scale, enough size in order to be economically feasible to operate. About 56% are chain owned, and most of those are for-profit chains. And the average cost per month is about $4,300. That gives or takes depending on the accommodation, depending on the level of care one is receiving within an assisted living, but that's an overall average. And I think the next slide talks about residency in assisted living facilities. The number of residents, 810,000, the last survey that was done by CMS. 71% are women, and the average age 84. The women continue to outlive us men. And average length of stay is about 22 months. Some a lot longer, some quite a bit less, but that would be an average. And then I think the next slide, we talk about tribal resources. And this is really sobering here. Out of all of those 300, and I think it was 26 pieces of land, reservations, and otherwise that Larry was just talking about, there are only 22 skilled nursing facilities, which total just over 1,000 beds in all of those properties throughout the United States. And only in even more sobering, there's only 14 assisted living facilities, which total about 230 beds, average at 16 beds each, on all of those properties. And there are 35 states without an assisted living facility at all. So I see that as a tremendous demand for, I would think, for these kinds of health services or residential/health services on those Indian properties.
David, on
Yeah.
that particular statistic, that the 35 states, that there are reservations in those states, right? That doesn't have an ALF facility.
Mm-hmm. I was assuming that. I didn't know specifically, but I was assuming that many, if not all, those states have reservations and no facilities. I mean, that's really, well, I can't think of the word. I mean, just a tremendous loss that we don't have those services for those people. And the source for that, by the way, was, I guess it says it up there, CMS Tribal Nursing Homes and Assisted Living Directory, February 2021. And then the next slide talks about common components or services within assisted living facilities. And I just kind of wrote this up to kind of summarize the big items. Assistance with the activities of daily living, and maybe assistance with one or two, and this would be, or many, this would be help with dressing or bathing or eating or toileting, that kind of thing. You have a licensed nurse, at least one licensed nurse. Most states, some states require an RN, most of them at least an LPN with an RN consultant as a backup. Private accommodations, the whole idea of privacy is really important in assisted living. Unlike many nursing homes where you have to live with a partner or even heaven forbid, be in some kind of a ward situation where there's more than 2 patients in the same room. Not too many of those anymore, thank God, but there are still some. But so private accommodations are important, and the whole notion of privacy is very important. Provision of meals and nutrition guidance if you need help with a special diet like sugar-free or salt-free, or that kind of attendance there. Activities and social opportunities. This is really important in assisted living. And the whole idea of companionship is very much part of what makes them so attractive. Assistance with pharmaceuticals. An outside pharmacy is usually involved, or a person's own pharmacy, and the staff at the assisted living will arrange to make sure that the residents receive whatever medications they're supposed to have. And then therapies if needed. They wouldn't be part of the staff at the assisted living, but there should be or could be contracts with physical therapists, occupational therapists, speech therapists that could come in and provide services as needed within the facility. Hospice support for those reaching the end of life. That would be a contract with an outside service, a hospice agency. And sometimes a secure memory support section, although, as I said earlier, it's only about 14-15% of the facilities that actually have such a resource associated with them. There are some assisted livings being built today that are just for memory support only. They don't tag on to a standard assisted living building. So I think that's kind of heartening to see. And in those environments, they're set up so the people will be safe, and they have usually an outside area that's fenced in a nice way, so they don't get lost or out on the street or something, and can still get some fresh air, go outside, and then of course inside they're kept secure as well. So the next slide, I think, let's see the next one there. Yeah. So today the household model is really what's preferred, rather than a gigantic institutional environment, but to try to keep it residential, keep it small, keep it as much like home as possible. 10 to 12 residents is ideal. 18 would be kind of a max, I'd suggest. The use of self-directed teams or universal workers is still in vogue, although it can be difficult to manage. Not everybody wants to be trained as a CNA, but that's kind of what is required when you go to a universal worker approach. And then the whole greenhouse idea really is embodying the Eden alternative. And the Eden alternative, let me just stop here and just talk a little bit about that. Many of you may know about it already, but the main thing about what Dr. Thomas tried to do is offset the plagues of in institutions especially nursing homes, of loneliness, helplessness, and boredom. Loneliness, helplessness, and boredom, which are just destructive to our health and well-being. And also the environment should be therefore caring, inclusive, and regardless of age, ability, or experience, a well-being kind of situation. And we thrive on companionship. So companionship is really important in developing a family-like arrangement, family-like feeling where people can be helping each other with some of their daily activities. And some of these facilities that are doing so well, you see the residents actually helping with meal preparation, with clearing the table, with doing some of the housekeeping, maybe some of the personal laundry, things like that. It all depends on a person's ability and the inclination, but the openness of it is what's important. And spontaneity is important too, variety and making things not so regimented. And so where everybody also feels a purpose, a reason for living, a reason to get out of bed in the morning, like Dr. Koff used to tell us. As advocates for older people, try your best to help people have and feel genuinely a reason for getting out of bed in the morning, and that they're still contributing. And that's a part of the assisted living model, as opposed to just in a nursing home where things are so regimented, and there's the medical model in place usually, and not a lot of opportunities to self-actualize.
David, I was just wondering, on your second bullet there, you're talking about universal workers. Could you explain what that means?
Well, my understanding is people who can multitask, and not all at once, but I mean, could be a housekeeper one minute, be a cook, be a server for a dietary, could also work as a CNA to care directly for people for their personal needs, help people with, transferring or toileting, that kind of thing, dressing. All of those things done by the same individual and being willing to do all those tasks as a universal worker. Does that
Thank
answer your
you.
question? Yeah. The sticking point is usually people, not everybody, I should say, wants to be trained as a CNA and do those clinical, or if you will, those personal kind of activities with people. Usually don't have a lot of rebuff from people who were asked to do cooking or housekeeping, those kind of things. But when it comes to the personal care activities, the volunteers are limited. And so consequently, the universal worker thing was in vogue for a while, a number of years ago, and it's kind of subsided now because of what I just said. It's difficult to get people who are willing to do all of those tasks and not have staff that has separate job descriptions. So the next one, Rebecca, if I'm not lost, let's see what that says here. Okay, residency to get into one of these assisted living facilities is determined by a variety of factors. There's a physician's exam that needs to occur, and it's done by the resident-to-be's family physician, their primary physician, and not a house physician, although some assisted livings, the larger ones, may have a house physician, but most of them do not. Then there's an interview with the administrator or the designee, and or his or her designee, and that's primarily to kind of get an overall picture of the resident and to see if there's a good fit. It's about chemistry, and to see if they're going to fit into the current resident body. You look at behavior, you look at habits, you look at try to forecast how they're going to fit in. It sounds a little selfish, but it's really in regard for all the other residents that are already there. Then there's a universal assessment instrument, the UAI, that's completed. And the UAI is something that's used throughout many care environments throughout the country. It's a CMS sort of standard document, but it's a way to look at the total person in a bunch of domains. See if I can remember here. They're looking at again, a fit and any needs they might have, any special needs, and if they're going to be able to provide those for those needs in that particular environment. You need to be at least 18 and over, and also a mental health screen is done, and there's several of those. There's one called the mini mental assessment or exam, which is basically a quick interview. There's also the MOCA, which stands for Montreal Cognitive Assessment, which is much more in depth to see if people where they are cognitively and if they have any serious behavioral problems, and also to ascertain whether or not they're going to fit in, or should they go to the memory support area if they have such a thing at the facility. And there's another one called the BIMS, or it stands for brief interview for mental status. That's often done for both assisted living admissions and nursing home admissions. And there's a geriatric depression scale, the GDS, which can be applied as well, depending on the judgment of the doctor involved, or the professionals who are doing the assessment, whether that needs to be applied or not. All these things to try to figure out whether the person is really going to fit in and if they can provide for the services that would be needed by the person. The need for some ADL assistance, and what are they? Do they need help with transferring, with bathing, with dressing, with eating, or what? And that helps toward setting up the plan of care, which I'll get to in a minute. Are they ambulatory? Are they able to self-preserve in case of an emergency? Can they get themselves out the door and out to safety if there's a fire, that kind of thing? In some states, you can be non-ambulatory, live there as long as there's appropriate assistance available for you to indeed escape a disaster and self-preserve. And you don't need continuous licensed nursing care. That's something for a skilled nursing facility to provide. It's not that you may need some nursing or some medical care, but not necessarily continuous. Or a ventilator or a nasogastric tube or a skin ulcer, dermal ulcer care. You can have a minor bed sore, but stage 3 or stage 4 are not allowed for admission, nor for continued stay unless they're healing, and no negatively aggressive behavior. You don't want people raising Cain and causing problems for everybody else. Let's go to the next slide. So most assisted living facilities divide their care, the care that they provide, into 3 different levels. And this is so they can attach a fee, a daily increase in the daily fee to the level, and then charge people more depending on kind of service, the amount of service they're going to receive, because presumably it costs more to provide more service. So level 1, occasional help with ADLs. This is the activities of daily living. Usually you can manage your own personal hygiene, you can manage your own medication, you may need some assistance in and out of the bath, and laundry and housekeeping is done by others. In level 2, assistance, now you need assistance with dressing or shaving, hair care, toilet transfer, limited access with medications. You're still kind of doing your own meds, but you need some access with maybe the LPN. They're helping to identify what med is correct for you to take, and also maybe pouring medications, that kind of stuff, and scheduling of events in your daily life. And level 3, where you really need hands-on assistance when you're toileting and bathing, you need a lot of help. And you need a lot of help with dressing and communicating. Often people have difficulty communicating and talking to their loved ones on the phone, that sort of stuff. So you need assistance to make that happen for you. And possible help with meals. You may need someone to cut your meat up and help position your food, especially if you're blind, can't see, and just general help to make sure that you're getting your nourishment. Multiple physical impairments are usually very evident at that stage, and medication management is almost a given. You need almost continual assistance with your medication. If you have any questions, just stop me, please. Let's go on to the next one. So for every resident in an assisted living environment, there needs to be a plan of care, or POC, and it's set forth shortly after admission. And it establishes measurable goals to improve or maintain their health. And also various interventions that might be needed are included in the plan. And things like you might need a walker or a wheelchair, or you might need assistance with in using those things. You might need a hearing aid, might need different glasses, different interventions to help make life easier for people living in those environments, and to ensure the safety and well-being of the people, and to maintain medical record that needs to be done. And all these places are surveyed by state, or by I guess it'd be state or county surveyors. So you also need to be able to have those records and things documented, so you can show that you have planned and you're doing these things that you say you're doing. And the plan of care needs to be reviewed and updated at least quarterly. So any questions so far? I think there's a bunch of them down here.
Hi, David.
Yes.
It's Becky again. I just wanted to let you know in the chat, there was Anya says, is the preferred household model implemented anywhere as of right now?
Well, there are lots of places. I don't think I can have one on the top of mind here, but I saw one in Holland, Michigan, for example. I don't remember the sponsor. There's one there. This is I really can't answer that. I just don't have that tip of my tongue, but I know they're out there, different places. California has a number of them. Florida has a number of them. You can probably Google it and we can find out, or I can do that for her later.
Okay. And then the other one, Larry, maybe you can help with this one, is are we going to have another training anytime soon? And I don't know if she's referring to assisted living or another subject. She says, I would like to have others take this training.
Well, as you know, we're recording this, and it'll be available on our website so that people who couldn't make it to this particular session can always pick up that session on our website later on. So it should be available. And I think it all depends on the feedback as well as we move forward. There might be other topics that we'll be covering sometime later on. But these first three are the ones that were requested by tribal leaders. And so we're prioritizing that. And there might even be a second round of different kinds of different topics that we'll be covering. So that would be my response to that question.
Okay, thank you. Yes, if you go to our NICOA.org website under newsroom and then click on videos, I believe that's where they'll be posted. And I'm not sure if Kayla will also have it posted on the LTSS Compass website. Another question from Valerie is how to pay for facility be covered. So I guess is that something we get into in the second half, David?
I'm sorry, give me that again, please.
How to pay for the facility to be covered.
Yes, I'm going to get into some of that funding or lack of in the next section.
Let's see. Tracy is asking, has there been any updates for the IHS to pay for assisted living like it is mandated in the Indian Healthcare Act?
On that one, I am going to respond, Becky, and this is, I think, something that a lot of tribes are beginning to take a look at. For example, if an IHS facility on your reservation is still run by the Indian Health Service, more than likely they will not be able to cover the costs, but they can provide, for example, a physician to do the assessment. So, and in some cases, there is a provision within the federal law that says you can bring a nurse aboard. I forget what that particular word is, but there's a way that you can get a nurse or a physician to be in the hospital through some kind of an agreement with the IHS facility. Now, on the other hand, there are some tribes that have taken over the entire realm of running that particular health clinic or that particular hospital. They call it self-governance, and it's compacted. And the tribe has the opportunity to allocate dollars in a way that meets their needs. So it is possible through a compacted IHS facility that they can pay for certain parts of an assisted living facility.
Thank you, Larry. Juanita is just had a one word no, and I'm not sure what that is about. If you could explain further, Juanita, we'll try to explain anything if it wasn't clear, or if you would like to make a comment. Y'all, I've noticed that if you go to the bottom of your screen and scroll around until you see the chat, the Q&A, and the more, if you click on the three dots that says more, you can raise your hand and then we can unmute you and you can ask your question verbally, which might be easier for some folks. So just wanted to let you know. Did David she's saying IHS does not pay for long-term care services, nursing home or assisted living services.
Again, on that one, if an IHS facility is still run by the Indian Health Service, very likely they will not. But if a tribe has compacted their dollars, then it's tribally determined. They could, if they wanted to, pay for some of the services within an assisted living facility as they would in a nursing home. So that would be my response, is that I think that there are a lot of opportunities under that the Self-Determination Act, whether they compact a facility or not. But if they compact, they have a lot more freedom on what they can do with those dollars that are no longer IHS dollars.
Thank you, Larry.
So Larry, if I may, there's also, I think it's a part of Medicaid. Many states are using what's called a Medicaid 915C waiver in their state plan, and it won't pay for necessarily, usually does not pay for room and board and assisted living, but it can pay for some of the associated services. I think you're talking about, like home health aid to come in, case management, counseling, maybe some other services, but not the actual room and board. So people have to qualify for that. They have to be able to qualify for Medicaid, but it's called a 915C waiver. And I imagine the Indian Health Service also has access to that through the Medicaid program, I would guess.
Tracy has a comment, says it's mandated in the Affordable Care Act as it was updated 12 to 13 years ago. IHS is to pay for long-term services. IHS is a confusing subject.
Yeah, and I think that this is where, IHS always says they don't have the money to pay for it. And that's been basically true because they've been underfunded for years and years and years and years. And so they are correct that sometimes they don't have the money to do it. Again, there's that with the Indian Healthcare Improvement Act and with the Indian Self-Determination Act, there are provisions for tribes can, one, either contract the IHS services, or two, they can compact the entire amount of money and they can determine how they can spend the money. Under the contracted provisions of Title I, they are required, tribes who take over, who contract a service are required to provide the same service at the same level of funding as if IHS would have done it. Under a compact, that money loses all its identity, and the tribe has the authority to reprogram those funds wherever the need is. And so there's a lot more freedom with a compacted IHS facility than there is with a contracted facility or an IHS facility. That would be my response to that.
Thank you, Larry. Shelley is asking, is there any training or certifications available for an individual to start up an ALF?
Used to be money available through the Older Americans Act, Title VII, or Title IV, actually. We talked about that earlier privately. And I don't think it's been funded though, Larry, have it? Older Americans
No, it
Act
has. No, I think that has been reprogrammed in another direction, not for that kind of training.
Mhm.
But I know, for example, that HRSA, the Health Resources Services Administration, has funds available to train auxiliary health staff. They train CNAs, they also train behavioral health technicians. I know that when I was working with the Gallup, the Rehoboth McKinley, we did a behavioral health technician training through HRSA funding. And so that they have funds available through HRSA to train, for example, CNAs, if that's what the need is in that particular community. So one of the things that we need to begin to think about is, where are all these other resources? We have a tendency in Indian country to look just to one, Indian Health Service, or two, the Bureau of Indian Affairs. But there are other entities out there who we can tap into, other resources that are out there that can be tapped into and provide that level of training. That would be my comment on that.
And most training for assisted living administrators is done within the assisted living corporations themselves. That's what's happening today.
And I realize that we are coming up to a break, I believe, but we've got two more quick comments. Valerie is saying, does that include 638 tribes, I'm guessing is what that's about.
Well, again, the 638 provision, the Public Law 93-638, allows tribes to contract services from the federal government. And under the Self-Determination Act 638, there's two parts. Title I, which allows you to contract, Title V, which allows you to compact. But before you get to the Title V compacting part, you have to have a certain number of years under Title I where you have a audit-free, no findings in your audits. So if you pass, I think, 2 or 3 years of no audits, no findings, you can apply to compact a facility or a program without any limitations on what you can do with those funds. So that would be, yes, under 638, that could be done, but under Title V.
Very good. And then one more comment before we go to a break was Shelley, maybe this is something we're going to talk about in their second part. What about a small business startup funding?
I would think that'd be possible depending on the priorities and the need in the geographical area you're talking about.
Okay. Okay, thank you. That was really wonderful first half of our webinar. I have, this is my little kitchen timer. I'm going to set it for 10 minutes and it'll go off and we can all take a little refresher. And then please come back because the second half is where we get into the nitty gritty of starting up a assisted living facility. All right, thank you. Well, the alarm went off, so the turkey's done. So let's go ahead and get started on our second half. Welcome back. And David, are you able to?
Yeah,
join us
okay.
again?
Hello, everybody. Let me gotta get my bearings here. So the actual development process, first thing that's really, really important is to put together a leadership group. And usually there's one or two champions that are part of the project. These are people that really believe in what of getting this accomplished and what it means for the community and the people who will serve, and they're influential people. Usually they're movers and shakers in the community generally, and so that's really important, to pull together a small committee of leaders that can begin to make this vision happen and have the vision. Need to also acquire sufficient seed money, and just thinking about that, that needs to be an open-ended amount of money. I don't mean to sound like it's unlimited, but as the project ebbs and flows, you need to be able to pull on the bank account a little bit, and so you can cover the initial expenses. It may be you have a philanthropic donor that could get that started, or get the bulk of it or all of it. Maybe the Small Business Administration could seed it. I don't know about the Bureau of Indian Affairs, but maybe that's a possibility. But in any case, you need to come up with some initial pot of money so you can begin to hire some of the professionals that'll be involved in getting the thing started. For example, the market study that needs to be done by a qualified firm, and it'll focus on competition, the need in the area, the location where you're intending to try to build this thing. And you can get some references, some suggested providers for a market study from Leading Age National, or your Leading Age state organization. Leading Age is a not-for-profit trade group for nursing homes, assisted livings, and continuing care facilities throughout the country. Or the American Healthcare Association, their National Center for Assisted Living could probably also give you, I'm sure they could give you references, ideas, what marketing firms you could contact to then do an RFP and a request for a proposal, and see which ones that the group thinks would do the best job and would be affordable. Need to establish some fundamentals, the mission and purpose of what you're trying to do. That's really important. And the type of company you want to have. Usually it's going to be a not-for-profit, I would think, in the case we're talking today, but there are a lot of for-profits out there too, but that needs to be identified, whether it's going to be for-profit or not-for-profit. And then some operating elements that'll be important. You need to establish the governance framework, the initial agents. Usually it's that committee I was talking about earlier, small committee. They become the initial agents with the Secretary of State and the beginning of the corporate entity. They take responsibility for the commencement or initiation of the new company. And then they in turn, once that's approved, would be instrumental in establishing the board of directors, selecting people from various backgrounds and so forth that would be helpful and meaningful in governing the development and eventually the operation of the facility. Need to comply with state regulations, zoning requirements. Communities are different all over. Some are easy about that, some are not, in terms of the zoning and the local requirements. The state regulations will be the same in your state, but different state by state sometimes. And there's required licenses. I'm kind of reaching the end of that slide. Is there license? There'll be a license for the facility that will be necessary to obtain, and you need the committee needs to know what's involved to get that license ahead of time. And of course, the administrator will have to have a license, or in some states, it's a certificate of housing management or something, not actually a license, but many are going to an actual license, like a nursing home administrator's license. And by the way, a nursing home administrator who's licensed can also operate a skilled nursing facility in, I think, every state in the nation. So if you have that, supersedes the assisted living certificate or license. Is there another slide, Becky, there, or am I? Okay, I guess that was the end of that one. important community resources to consider. This is real important for your project. Is there the needed labor nearby, both clinically, the healthcare folks, nurses aides, and nurses, at least LPNs, and probably an RN too, at least one. You'll need to have on board in a consultant capacity. Dining services, people who can cook, people who can serve, that's important. Maintenance, housekeeping, same thing there. People can fulfill those duties, and some administrative help. You probably will need a business manager, somebody to run the front desk and reception, those kinds of folks. Do you have the labor force nearby or close enough to be able to pull on to staff your facility? And then the proximity of some anticipated services and providers. It'd be great to have if you have a hospital not too far away, and all that goes with that. Physicians, of course, a home health agency that's relatively close, various therapists like physical therapists, occupational therapists, speech therapists that you'll want to probably contract with. A hospice agency, same thing, have them hopefully nearby to help with end-of-life care. And food products and supplies that go with not just dietary, but also maintenance and all the other aspects of running a facility that requires some kinds of supplies. In transportation, are you close to a bus line? So your employees can get to work and back and forth if they need to do that rather than drive their own vehicle. And technicians that will service your heating and ventilation, air conditioning systems, and other equipment. IT is another one. Good to have IT tech somewhere in the vicinity that can come in and help with your computers and all your AI kind of stuff that's going to probably be in vogue and be in the case in your new facility. More and more, as you know, we're going to technical advancements in all these operations. So if you have a question, stop me. I think Becky's suggestion was great. If you I don't know how to do it on your computer, but if you just go to voice control and just ask the question outright rather than the chat, then I can just stop and listen to you.
And I'm sorry to jump in, David, but
Sure.
Cornelia says, I think she was speaking about licensure, perhaps. Would that be the same for adult daycare? Oops.
You're talking about licensure for assisted living?
I think so.
Yeah, that's a different kind of thing. I'm not too familiar with licenses for adult daycare. I know it'd be different though, for sure. Maybe some programmatic elements that are similar, but that'd be a different animal.
Okay, thank you. No, I don't show any other comments or questions at this point.
Okay.
Next slide.
Yeah, the next one talks about physical planning and construction. Need to use that market study to, the results from it to determine the scope and size of your project. It's maybe obvious, but that's going to determine how many beds you can afford to build and operate, how large your project will be, and that'll also dictate it'll dictate its financial success. It identified the location and the land cost where you want to build your project. Select the design and construction team by using usually request for a proposal process. And here's another place where those large national trade organizations can help with some suggestions. They all have a list of the better architectural firms, engineering firms, construction teams that deal with housing and programs and services, facilities for older persons, long-term care facilities, including assisted living. So I would, if you don't have enough resources locally or enough known good ones to contact, those would be good sources, Leading Age or American Healthcare Association. And then determine the architectural and engineering cost after you get those RFPs, and so you get that figured out, nailed down, and baked into your projections. Determine the site development costs, including the local requirements. And I was in charge of building a facility in Sarasota, Florida one time, and I was amazed with how many local requirements and costs were involved for all the permitting and all the review of plans and coming out and checking the construction and on and on and on and on. So don't be surprised about those if that exists in your particular community. You need to investigate that ahead of time so there's no surprises. And determine the construction cost, including the cost of permits. I'm just kind of talking to, but the construction cost will be based on the square footage size of your facility to be, and that can be calculated by your architect and by your general contractor. And there's usually a lot of ebb and flow there as you put together design and the footprint of the project. And a lot of times the visionaries will over project, and then you get to the bottom line and say, oh my goodness, we can't afford that, it's too much money. So you'll have to find a way to cut back off. That's common, and still accomplish your mission. And then establish a budget for all your fixtures, furniture, and equipment, FF&E it's called. And your interior decorator can help with that. You'll have to have that kind of a company on board as well as part of the design team, and they can help you establish that. And that's another area that often has to be honed back because you just can't afford a sofa in every room or chandelier everywhere. And you have to be somewhat prudent about it and still make it turn out to be very nice. And determine a contingency amount to maintain through the course of construction. And that's for change orders and things that inevitably happen. Inevitably, there are things as you go down the line that, oh, I want to do this instead of that, or let's make that room a little bit bigger or something, change the flow of the use of the facility differently. So there's architectural changes and construction changes, and those cost money. Usually contingency amount is anywhere from 15 to 20% of the construction cost of the original construction estimate.
Next slide.
The next slide. So now we're going to talk about figuring out the budget to run these places. And need to do an operating cost pro forma or projection. Assume, and what I do is assume the full cost of occupancy for 1 year of this facility you have right now have on paper. So pretend for 1 year it's going to be operating at full bore, meeting the occupancy objective. Maybe it's 95%, 95%, somewhere in that realm. And what will be the inherent costs associated with running it that way? So you're going to have these key personnel on the payroll. You have to have the administrator and whatever he or she's going to cost, a lead nurse called the director of nursing. That's probably going to be an LPN. And underneath that, you'll need a contract with an RN, a dining services director, supervisor, business manager, maintenance, environmental services supervisor or director, and other staff to take care of all these people you're going to have in the building: aides, cooks, servers, maintenance people, housekeeping people, receptionists, activities personnel. And don't forget about activities. You need to have somebody who's full of life and full of energy and full of ideas to help people not be bored. So all the costs for all those key positions need to be baked into your projected budget. Any questions about that? And I wrote here a note, consult state regulations regarding the required qualifications of the administrator. They generally need to have at least a couple of years of college and need to be at least 18 years of age and be able to or have already passed the exam to become licensed. That's important. Either have passed it or be able to pass it. And what else do I have here? The
Director of nursing.
The director of nursing needs to be at least an LPN. I talked about that with an RN consultant available. The dining services director doesn't have to be a CDM, a certified dietary manager, but you're going to have one on staff, a certified dietary manager, and probably an RD or registered dietitian as a backup on a consultant basis to make sure that the meals are appropriate. The state's regulations are going to require that appropriate diets are given to people per whatever the needs are, and that you're indeed setting up menus that satisfy those diets. And then other personnel costs, the next slide You're going to want to deal with employee benefits, vacation and employee health insurance, and also paid time off. And when I say paid time off, you also want to include some kind of a plug in your budget, operating budget for coverage when people are on vacation, especially the frontline people. You need people to keep serving and doing housekeeping and doing those important frontline tasks. The administrator may be able to be gone for a week or two without replacing, but those others, so you're gonna have to bake in the cost of overtime or somehow replacing the time lost by those people being out of work. And then payroll services to manage the payroll function itself. You may be able to do that in-house, or you may have to farm that out. Workman's compensation insurance with the state, and that can run some money. You've got to bake that cost in. And then let me go to the right side here. Other operating costs of food and supplies based on the occupancy and the number of meals. You can extrapolate and calculate the number of meals that for the full year that you would be rendering, and what would be the cost of those. And dietary personnel experts can help you with food costs, per meal costs that can be baked into that calculation. That data exists. Also, those national companies I mentioned can be resources for you as well in that regard. Maintenance, housekeeping supplies, medical and related supplies. There are some factors for that available too in the literature. Activity supplies and entertainment, that's going to be kind of open-ended, but you certainly need to put some money in the budget for supplies and to be able to have some nice activities going on, keep people happy. Office supplies, utilities. Here again, the engineering architectural firm can help you in the contractor as well, calculate and forecast the utilities based on the equipment you're going to have to heat and cool the building and light it and so forth. Liability and D&O insurance, cover your board of directors and also any liability might occur, God forbid, in the operation of your facility. You'll need an insurance expert to help you with that. Vehicle and transportation costs. All of these facilities have at least one vehicle with a lift on it that can accommodate a wheelchair or two to take to a doctor's office, whatever. You're going to want to have some kind of a nice vehicle and to be able to advertise that you have that transportation available for your residents. Property taxes. Some communities, some counties don't require property taxes, especially if you're a 501c3 and not-for-profit organization. Others do. Depends on your locale and what the requirements are there. And then annual debt service can be based on your loan, your mortgage. That has to be put into your projected costs. And annual depreciation, and your accounting firm should be able to help you with that in the life of your assets, put in the depreciation factor. Then on the revenue side, which is the next slide, I believe. Based on the project size, number of beds, and that's per the market demand projections, estimate the occupancy at a steady state again, and then establish pricing or daily rates by dividing the operating cost, the overall cost, by the average daily census or occupied units. And then that'll allow you to at least establish a pricing range. And then underneath that, which is more difficult, I think get some help from operating facilities and through those national organizations I was mentioning, but in order to do some estimating about levels of care and the fees associated with levels. And the hard part is predicting how many residents will be in each level, therefore how many upcharges you'll be able to bake into the pro forma, the projected revenue. And it gets a little dicey then, and that's when you really need a consultant to help you figure those things out and be more precise about that element of the projection. And add a contingency margin to your rates of 10 to 15%. That's basically the profit that your facility should be able to maintain or create by the end of each year. And then for not-for-profits, that goes right back into the organization for better wages or better equipment or other for growth, other contingency elements. And then this is where we talked about, we already mentioned a little bit, but this Medicaid 915 waiver that's available to pay for some services within an ALF for the residents, but not the actual room and board, although there are some exceptions where through some of the state plans, 915 waiver will pay for a portion of room and board in some facilities for people that qualify. And those residents will need to qualify for Medicaid in the first place. But where that's not the case, where the state would allow payment for some of the room and board costs, they could receive services from the outside, like a home health aide or case management or counseling, those kind of things through that 915 waiver. It's really a waiver. It's really 915 is really set up for home and community-based services for people in their actual homes, but it can apply for people in this kind of a home environment as well, in a assisted living facility. And then on the startup, again, startup planning and costs established to fill up assumptions. This is now you've opened your doors, you're starting to bring in people. You need to, but first you need to make some assumptions about that fill up rate. And for example, 8 residents a month during the first 6 months, and then also account for some attrition. You're going to have some people attrit out. So you need to bake that into your projection as well. Most facilities take 4 to 6 months to get up to a steady state, sometimes a little longer, depends on your market demand. And projected revenue for the first year is estimated accordingly based on that startup process and regimen. And then when you're going to reach the steady state and be able to cover your costs with the revenue coming from your in-house residents. And the largest chunk of expense will be during that first startup period. And that's when you really need to have what's called working capital. I guess I talked that a little further down here, but and there'll be some additional costs. Personnel and supplies will be added as the facility fills. You add more frontline people in particular, and in order to take care of everyone you have in-house. So those costs need to be baked in over time. And again, it's critical to have a certain amount of sufficient amount of working capital to be set aside to offset the revenue loss during that startup period. And usually that's at a minimum about 90 days to be able to support the operation without any other revenue for at least 90 days, sometimes longer. And it would be really good if you can be, if you have a way to be flexible on that. And the 90 days is kind of a rule of thumb, but it might take you 120 days, it might take you longer, it might take you less. Depends on your market and the need and all the advanced marketing, if you will, that hopefully has gone on in anticipation of the existence of your new building. The thing about assisted living clientele or residents is it's very how do I say, immediate. It's not something people plan to do months and months ahead. It's need driven. You know, they start to have the need, start to be aware of the need pretty in the now. You know, they might have fallen, broken a hip, and now I can't walk or transfer very well. I need to have assistance. I live alone, and what am I going to do? And you know, it's not something you plan ahead, like to go into a big retirement community. You might plan for months or years ahead or something. So the market is in the now, but you can be advertising and telling the community and informing them about this great place you're going to have and how it's going to meet the needs of many people. That can be done in advance, and so it's ready to go when people need the service. And I think the next one, this has to do with funding opportunities, and this is by no way a complete list. I just threw down some ideas here, but many places are financed by bond issues or bank loans, traditional mortgages, loans. Federal assistance could be available. Tribal governments may have some money. Maybe some grants available to help offset costs. Foundations can be very helpful, and there are a number of them that are interested in seeing this kind of facility developed in locations that have a real paucity of services. Individual bequests and donations. And by the way, if you're a 501c3, these donations, cash donations from benefactors can be tax deductible for them. So that can be very, very attractive, especially for people with, with a lot of money. And then you may need to want to name the lobby after them, or one of the buses, or another part of the facility or something, in a way that'd be appropriate, that your board of directors would deem okay. There's associations and group sponsors, other donors that might be possible, depending on your area. The land, I've often seen the land actually donated by a benefactor or a church group. And again, that could be a nice tax deduction for an organization or for an individual or family. Discounts are common from contractors, suppliers, others that are part of the project along the way to reduce your overall cost of getting it up and getting it running. And the Older Americans Act, Title III, Title VI, and I think, Larry, you were going to talk about that a little bit here. That's your bailiwick.
Yeah, and in the Older Americans Act, there are services that can be paid for, and so that those are potential funding sources, both Title III and Title VI. As some might know, Title III is operated and managed by the states. In some areas, they're called area agencies on aging that have those funds available at the local level to provide certain kinds of services. And so that's a pot of money that's available, especially in the assisted living program. Secondly, you can also use the Title VI money to do that, to help with counselors or with maybe even the training of CNAs. One of the things that I wanted to mention to people who are interested in the training aspect is that I wanted to share an activity we've been working with a group out of Idaho with the Shoban tribe up in Idaho. They're training 10 CNAs at the high school level, and they're utilizing resources from the University of Idaho, and the State Idaho Commission on Aging is assisting them, and they're buying the equipment through the University of Idaho as well, so that these young people can be trained as CNAs. And so that's an opportunity there in terms of training and just resources that somebody mentioned earlier in the conversation. But the Older Americans Act is a possibility. And I think that that's an opportunity to identify some funds that might be available through that particular act. Thank you, Dave.
Yeah, thank you, Larry. That's very good. I think the next slide talks about sustaining occupancy after you're up and running. And I think these are important as well. Using your referral network, other nursing homes or hospitals, home health agencies, physician offices, and others. I didn't list here, but elder law attorneys, trust officers, ministers and priests, rabbis, those are all good resources to discover potential clientele out there, people that might be might benefit from being a resident in your new facility. So, and that's something that you keep doing continually. You don't just do it once. Maybe develop a newsletter, have a way to stay in touch with all these people that could be so important to your occupancy, frankly, and fulfillment of your mission. Media and advertising cost you some money there. Sometimes you can get what are they called? The public service announcements on TV and so forth for free if you're not for profit. Special events at the facility, open houses, let people come in and see how happy the residents are and what a great residential, warm, loving environment it is. Host community groups, same kind of reason. And have excellent surveys when the state comes in or the Department of Social Services comes in and surveys your operation, have a good result. And then if you can, tout that in the media so you'll get your feather in your cap and pats on the back, and the community in general can know what a great job you're doing taking care of our seniors. And there's probably many more, but those are the ones that came to mind right away. It's very important to work those that referral network on an ongoing basis. In most places, in addition to sometimes the administrator spends some time at it, but they usually have some kind of a admissions person on staff that helps facilitate these kinds of contacts. Well, reputation is really important, having good surveys. The last slide, I think, has to do with just a summary. I'm just wrap it up here before we take some questions. It has to be a market demand study done by a qualified marketing firm to see what the need is in the particular area you're talking about, possibly developing a facility. Should have the resources available to operate the facility, and financial to build it and so forth and to get started, but then also the labor nearby enough to staff the facility and supply food and other accoutrements and items that you need to operate. And you need to have the leadership and commitment at the top level in that initial executive committee and also on the board to sustain the operation and to not just keep it going, but keep its mission going in a way that really meets the needs of the people you're trying to serve in a way that's wholesome and good and respectable and with dignity and with proper attention and really with love. And putting your ideas into action. That's what we talked about actually when the mortar hits the bricks and you get it built and get it running, all the different elements that are associated with that, and then managing and sustaining your ALF using some of the elements I just described with referral agents and media advertising, special events, open houses, and excellent surveys. So that kind of concludes my remarks. Any questions? Be happy to try to answer.
I think, Dave, in this regard, this particular seminar, webinar has been one that we try to make it responsive to the needs of tribal leaders who see a need out there. And with the funding that we receive from ACL, Administration for Community Living and Administration on Aging, these webinars have been made possible. Initially, we had, prior to the pandemic, we were to work with one tribe for the entire length of the project. We couldn't do it because of the pandemic. Some tribes closed down their borders. We couldn't go in. And we felt like maybe there's another way. And with the technology that's out there, I had to learn how to use Zoom, WebEx, all of those technology and platforms that are out there. And it has been one heck of a learning curve. But we felt like by doing this, we can open these opportunities, these webinars and training opportunities to more tribes than just one. And so, Dave, you've been a part of these discussions. You have shared your information, your thoughts, and your experience with all of these individuals that are out there listening in. And I want to thank every one of those individuals who have an interest. And I know that in looking at all of these things to consider, it is a lot to think about, and it is one step at a time. It's not something that's going to happen overnight. But I think the most important part, as you mentioned, Dave, is to have that vision. Is this what you want? Is this how you want to do it? And is this who you want to do it with? And in that development, we did a webinar yesterday talking about partnerships. And I think in the development of a facility like this, it's going to require developing these collaborative relationships, partnerships with non-profit-making organizations, associations, with lawyer groups, with the police department, the educations, the school systems. All of that requires that partnership, and it's going to require, and I hate the use of this old cliche, think outside the box. I would rather use think outside the circle, to begin looking at how we can accomplish, how you all can accomplish the dream that you have. And so for me, from the National Indian Council on Aging and the staff and the board that I work with, I want to thank you, Dave, and I want to thank all of those who are listening in. And we really look forward to seeing growth in this area, because there is going to be a need, not just today, but more need in the future. So again, thank you very much, and looking forward to your questions that will be coming up. Thank you.
Thank you, Larry. I see on the chat box here, there's a couple things I might be able to answer. The D&O insurance I referred to has to do with directors and officers liability insurance that your board of directors would want to have, and also apply to the key management of the facility as well, like the administrator and director of nursing. And someone asked about market study, market research, how many years would it be viable? Usually it's a 10 to 15 year window, reach out, sometimes less, but usually it's 10 to 15 years. They try to look at, project the market and using census information and other factors with age and income qualified individuals within the catchment area, the market, primary market service area. And someone asked about getting assistance from consultants. I'd be happy to help you find some of those. I just need, I know people all over the country, as Larry does too. Just need to kind of sit down and make my list and do a little research, but there, and I'd be happy to help personally if anybody has any follow-up questions after this is over. But I know they're out there. There are people that can help. And another good resource would be those national organizations I mentioned, the Leading Age and American Healthcare Association. They maintain a list of consultants that could help as well.
I think that one of the things that I just wanted to mention as well, Dave, is that in my years of experience working out in Indian country, most tribes do not have the resources to build a facility right then and there. In terms of, like you're talking about property tax, most tribes do not have property tax, so it's not going to be that big of an issue. But in terms of the building itself, there's a concept that I've heard used, and I've seen it happen, where they call it design build companies who specialize in that area, who can also at the same time find the necessary funds to build the facility and then lease the facility back to the tribe over a period of time, so that by the end of, let's say, 20 years, the lease has been paid off and the building belongs to the tribe. And so there's all kinds of creative ways of finding the necessary funds to operate a facility and not have to put the cash up out front. So that's one way that I know of that has happened in Indian country, where in the places that I worked before.
Yeah, that's a really good suggestion, and I've seen that happen elsewhere. Yeah, be careful with the paperwork though, so that you at the end of whatever time period it takes to pay off the mortgage, you in fact really own it, and they don't still have a hook in it. Yeah, and everybody wants to make a living or make some money off the deal, so just go in with your eyes open. Yeah. Any other questions?
I got an email from Juanita that says, talking about adult daycare, and the topic of this is assisted living, but do you want me to share that comment? Would that be
Sure.
appropriate? Or, okay.
Sure.
She says, I'm currently working on an adult daycare in New Mexico because we would like to be reimbursed for services from Medicaid, veterans, and other insurances. It will be a requirement for us. Of course, there are other alternatives for reimbursement for services, but this is the avenue we're pursuing.
Okay. So is there a question in there somewhere?
I think it was just an observation about adult daycare and reimbursement.
Okay.
I think that with Juanita's comment, and I think that she's doing the right thing in my view, because a lot of the people, back when I started in the field of aging, back in the early 70s, a lot of our elders, one, were still very traditional. Two, they were not as educated. Today, you know, these elders that are now here are a lot of them are Vietnam era veterans. And so now we're looking at the Veterans Administration as possibility for pay for some of these services. And so I think that that's a very creative approach to looking at where are the funds by taking a look at the population that you're serving. You know, some of them are old IHS or BIA workers that are covered by federal insurance. Some of them might have taken out long-term care insurance along the way. So those are possibilities. And I think that Juanita is being very creative in her approach to finding those resources.
This is sort of a small world, Indian country, and when someone says they're doing something, maybe some of the other attendees might go, hey, let's do it together. So things like that happen on these calls.
It's almost a topic for another webinar on the finances, on the funding possibilities. I know I've heard there's some foundations out there that could be helpful as part of their mission and trying to help humanity wherever. And there's as we looked at this, there's such a tremendous paucity of demand, I would suggest, at so many of these locations. You know, Larry, you mentioned 326 properties out there, reservations or similar. And 35 states have no resources at all in this regard.
Well, you've gotten a lot of wonderful feedback in the chat, David and Larry. Thank you both very much. Is there any other topics that you'd like to cover?
No, I appreciate the opportunity, and I hope we were able to be helpful and wet some whistles, and people will be interested in pursuing their dream a little further with respect to assisted living. If I can be helpful, don't hesitate.
And I think that for those of you out there who are interested in following up with Dave, we got his name, we got his email address, where you can contact him if you needed additional information. So again, thank you all very much.
All right. I think
Thank
that
you.
concludes our webinar today. Thank you both.
Thank you, Larry. Thank you, Rebecca. Bye-bye.
Bye-bye.